Good morning, everybody. Thank you so much for being here with us today. I am really pleased to talk about, as we always do at the beginning of the meeting, where we are. Now, I'm getting very close, shocking as this is, to the end of the year. And again, two things we always keep in mind. One is that any loss in this battle is tragic and is too many, but also keeping in mind where we are in this work and what a testament it really is to the great value that we are good fortune we have in this county to have all of you as partners. And I know some of you have been with us since the beginning. Some of you are newer members, but I was talking the other day about the fact that now 12 and a half years into this work, I frankly could not have imagined we would get to the place where we are now, considering where we started. And that is that where we are now and mid-October, we have seen across our county 104 deaths due to opioids. And those are the accidental overdoses. But that represents a 30% decline from where we were last year at this time. And as I always say, if you think about not only the person who loses their life, but in a very conservative way, think of that death affecting 10 people. You see, first of all, not only the tragedy of what's happened, but also just the number of people whose lives have been saved and the impact that's had in our communities. And that, again, that really is due to the work that we have done together and so many people working in this area. What my concern, and I've said this every time for the last few months, my concern does continue to be that as good as that is, we've seen almost a 25% uptick in the number of non-accidental deaths by suicide with the use of opioids. And keeping in mind as well that our bar for calling something a death by suicide with opioids is very high. We do not do that unless there is an unmistakable indication through a note or statements or something that that's what's happened. But that number has climbed. The numbers are still small. We've gone from 10 to 14. But that's a big increase. So that is clearly where we now need to change and shift our focus somewhat to that. But what we're going to talk today about is, again, something I think that is forward facing and looks to the future in terms of who we're really helping. And that is, we've talked a lot at these meetings about stigma, and probably one of the communities most often stigmatized around the use of opioids is pregnant and immediately postnatal women. And that stigma is deeply embedded both in the criminal justice system and in the healthcare systems. And, it can affect people when they're pregnant, when they're postpartum, when they're parenting, and especially if they also have difficulty getting services or something is causing them, whether it's the stigma or life itself, causing them to skip treatments or avoid treatment. It's an issue that has more and more come to the forefront of these conversations. And just to think about these numbers, in fiscal year 2023, DCF's annual report indicated that there were 1,453 51As that were filed on alleging neglect due to a substance-exposed newborn or a substance-exposed newborn who was experiencing neonatal abstinence syndrome. And 750 newborns were exposed to substances across Massachusetts. That's a big number. That's, again, if we look not just at the person in that number, but what's the circle of people affected, the rest of that family, the other parent, all of those come into play in thinking about how that stigma is touching people's lives. And, just this past April, 6 months ago, Mass General Brigham unveiled a new policy saying that their hospital would no longer be filing 51As alleging abuse or neglect solely because a baby was born exposed to drugs. And going forward, they limit their reporting to cases where there is a reasonable cause to believe that the infant is suffering or at an imminent risk of actual physical or emotional injury. Boston Medical Center had made a similar declaration in their guidelines in 2021. And in light of that changing landscape and, as I said, the continuing conversation around this, I think it's important that we understand doing this work, the effects of substance exposure on newborns and how we can best support those new mothers who either are still battling an addiction or in recovery. A recent study published in the Journal of the American Medical Association Open Network looked at the 90-day readmission rate for substance exposed newborns, which was significantly higher than those babies born who were not substance exposed. That's concerning, but the reason for the readmission, whether it was seizures, failure to thrive, a traumatic brain injury, a skull fracture, or other instances of maltreatment, make those statistics even more alarming. So think about that. There's a baby who leaves the hospital in good condition and within 90 days is back in the hospital. Some of those potentially being physical effects of what they were exposed to, or others maltreatment. And the researchers concluded that there really is a critical need to provide those babies and their families with both short and long-term care. And my hope is that we're going to leave this meeting today with a better understanding of how we can support the individuals who are struggling or in recovery, making sure they have access to prenatal and perinatal care, and their babies leave the hospital safe in the hands of the adults who are caring for them. We met just yesterday in a related matter with a new program we're thinking about bringing to Middlesex, which would have folks interacting with families who see children where there may not be the obvious signs of concern, where there may not be enough for somebody to be filing a 51A, but really educating professionals about other red flags. We always, and I say this often, I would always rather prevent something happening than address it after it's happened. So how can we make sure we're giving support and then we still are mindful of what might be red flags of things that will bring those babies back to the hospitals? So we're going to begin today. We're fortunate to have 4 speakers here today. We're going to begin with Catherine McLean. Catherine is the evaluation manager for the Healthcare Transformation and Innovation Team at the Mass Health Policy Commission, a group that has been helpful to us since the very beginning of doing this work. Catherine has led the evaluation planning, the data design and collection, and the report development for the cost-effective coordinated care for caregivers and substance-exposed newborns, which is more easily referred to as C4SEN investment program. She's contributed to the evaluations of several other Health Policy Commission investment programs focused on care delivery transformations. And she's joining us today to share some information about the program that they've developed and ways that you can be using that or resources they can provide. So Catherine, thanks for being with us this morning.
Good morning. Thank you so much. Yes, I'm Catherine McLean on behalf of the Health Policy Commission. I want to thank DA Ryan and the task force for having us here today to talk about our C4SEN program. So we will. Okay. Everybody can see the slideshow? Okay, great. So we're going to start today with a brief overview of the Health Policy Commission and our C4SEN program, then move into an overview of some quantitative data from the program, and then discuss the patient experience evaluation and findings that we did, again, as part of this program. So the Health Policy Commission is an independent state agency charged with monitoring healthcare spending growth in Massachusetts. And the mission of the HPC is to advance a more transparent, accountable, and equitable healthcare system. And the overall goal is better health and better care at a lower cost for residents across the Commonwealth. The HPC has sort of four main levers to achieve these goals. We're going to be focusing today on the partner goal or the partner lever, and within that very specifically on the grants we're able to give through our investment programs to help hospitals and healthcare organizations implement innovative new care models. And so that brings us to our cost-effective coordinated care for caregivers and substance-exposed newborns program. This built on prior work that HPC had done in expanding access to MOUD through hospital emergency rooms and working on the inpatient side of care for infants affected by neonatal abstinence syndrome. And so this program was a 24-month-long program that took place between 2021 and 2023 that was really focused on the caregiver, meaning here the birthing parent, and the substance-exposed newborn as a dyad and providing wraparound care. There were 5 awardees in this program spread across the state. Though I do want to note Mercy Medical Center had a shortened implementation period, and so their data is not included in this presentation. We're just focused on the other 4 hospital sites. So again, the program was really focused on ensuring evidence-based care for both the caregiver in the form of access to MOUD and psychotherapy, and for the infant in the form of ensuring attendance at well-child visits and connection to early intervention. And then we also really wanted to make sure there was wraparound care to address other needs that the dyad might have so that they could appropriately engage in treatment, and that care be provided free of stigma, bias, or discrimination. Our program evaluation had several components. We're going to be focusing today on quantitative data collected from the awardee hospitals and patient experience, which was evaluated via both surveys and interviews directly with participants from the program. So moving directly into the quantitative data, starting with just a broad overview of the enrollment within the program. We will have the opportunity later in this meeting to hear from our awardee partners at South Coast Health about their program, which was by far our largest. So again, caregivers here is the pregnant or birthing person with substance use disorder. The vast majority were opioid use disorder, though we did allow hospitals to enroll some folks with either polysubstance or alcohol use. The infant is the substance-exposed newborn. And then we did also, at some programs, extended the option for any children who were previously born to that same parent, substance-exposed and still young enough to be eligible for early intervention to also enroll, though that was a fairly small number. For the race demographics of the program, it was predominantly a white population with small populations of those who identified their race as other or Black or African American, and then even slightly smaller populations who identified with 2 or more races or as Native. So want to highlight 2 important points here looking at caregiver enrollment in treatment. First is in the blue chart at the top, the number of participants who enrolled in C4SEND programs while not actively engaged in either taking MOUD or participating in some type of psychotherapy, whether that be group or individual. The programs were then making the effort to get folks engaged in these treatments, and especially want to highlight the high level of success where 3/4 of the people who were not in MOUD at enrollment in the program did get engaged in that care during the program. With psychotherapy, definitely there were some challenges with regard to workforce shortages and accessibility of that care, long wait lists, et cetera, that meant that did lag a little bit. But, programs made really, really strong efforts to help make those connections. And I know several of them, either at some point in the course of our program or as they've continued their programs since, have actually hired behavioral health providers specifically to increase that accessibility. The other thing I want to highlight in the bullets down below is the high rate at which people are, in general, participating in this treatment. So of all the caregivers who enrolled in our program, the vast majority had some history of having taken MOUD in the past, and 63% had some history of psychotherapy. And then part of the reason why, even though our total enrollment was over 200, but the number available to enroll in either MOUD or therapy is so small, is because many folks were engaged in those, and the programs really supported them in helping to continue that care through their pregnancy and postpartum. So almost 80% taking MOUD, and over half engaged in some form of psychotherapy when they enrolled in the program. We're also able today to share a little bit of data that comes to us from our colleagues at the PNQUIN, the Perinatal Neonatal Quality Improvement Network of Massachusetts, and their Perinatal Opioid Project. So what this compares is awardee hospitals, so hospitals that got a C4SEN award, but looking at their total opioid-exposed newborn population, not just those who enrolled in the C4SEN program, as compared to non-awardee hospitals of similar size who were reporting this data in the same time period as our C4SEN program is happening. And so we do want to highlight the higher rates of participation in both MAT, which is alternate language for MOUD and reflects the language that PNQUIN used in this data, and exclusive MOUD, meaning that folks were only taking their prescribed medication for opioid use disorder during their pregnancy. And that the rates are higher at our awardee hospitals, which I think speaks to the impact of having a program like this in place. But also really to illustrate that even at the non-awardee hospitals, almost half of the births were only exposed to their MOUD. And I think that that's a helpful piece of information for caregivers and community providers to have, because I think that may not align with what some of the current perceptions might be of this population. So also, again, talking about this wraparound care with health-related social needs, this was a high-needs population. Almost 70% of those screened had at least one health-related social need. And as you see, housing, which here refers to any sort of housing insecurity, not just being unhoused, though we did have those folks engaged in our programs and supported by our programs, was the highest level, but then also fairly high rates of challenges with food insecurity and transportation. And I think as the DA spoke to in her introduction, have to make sure that folks are taken care of with those needs so that they can appropriately engage in their treatment, recovery, and parenting. So then moving into care for the infant, we are looking here at attendance at the standard well child visits that occur in the first year of a child's life. There are 7. And here, just do want to highlight, this is the missed appointment rate. So these very low numbers are a very good news that folks really are making it to these appointments. In most cases, the denominator, so the number of infants who got to the point of this appointment sort of does shrink over time, even as the missed appointment rate is going up, just because some infants were not yet 6, 9, 12 months of age by the time the program ended because they enrolled later in the program, and some folks did leave the program early. But you do see a little bit of a trend of an increase in missed appointments, but I think this is helpful education for pediatricians and those that work with them in the community, a real focus on making sure folks stay engaged in attending those visits. The 12-month visit, we had a fairly small population of infants that reached that milestone while in the program. So that may be part of why nobody missed that appointment. But I do also think that 1-year milestone is a big one. And so it's much more top of mind for folks to be attending that visit. And then looking at early intervention, here in the navy blue is our C4SEN program data. And so you can see almost all of the infants in our program were eligible for EI referral. Generally, that was based on criteria of either of diagnosis of neonatal abstinence syndrome. And then close to 3/4 did receive an EI referral while they were in our program. So, again, a great success for our awardees. And then in the orange, we see data again from PNQUIN about non-awardee hospitals and the rate of referral, which is a bit lower, though there is some uncertainty because nearly 40%, the referral status could not be determined. So it's very possible they got one from another site, their pediatrician later on, because this is data only from the birthing hospital. We did note a lower level of infants completing their first EI visit following referral, and did do a lot of work with awardees, and awardees did with their populations on, understanding what was behind that. And in some cases, there were some sort of challenges and reluctance and concern about stigma that did lead folks to be a little bit less likely to engage in EI visits. And so I think that's a real area for programs and EI providers to kind of partner on for more education and to encourage uptake of the EI visits, because we know they can be so helpful to these children. The other thing, though, to note in terms of completing the first EI visit is this program did run starting in the fall of 2021. So still, if we can all remember back there was some backlog and some limitations on the EI offices due to COVID that may have also contributed. All right, and so now we'll move into the patient experience evaluation and some of our findings. So, at the HPC, I think we've really tried to make an investment in recent programs in understanding and elevating the patient voice, because we know that engagement and buy-in is so important to the success of these programs. And we want to make sure that these programs are meeting the needs of caregivers. And then in the case of and participants, and in the case specifically of the C4SEND program, because we had a goal around care free of stigma, bias, and discrimination, we really wanted to understand those experiences. We worked with a contractor to preserve participant privacy. So it was staff from the contractor who did speak directly to the participants and collect the data. We offered a survey and an interview. We made several changes to eligibility to increase the number of participants, but all who participated were several months postpartum at least, and in many cases had been a part of the program during their pregnancy, and so had been with the programs for many months at the point they provided us with feedback. Really quickly before we dive into results, just highlighting a few limitations. Largely, these are from the small sample size that we have. We had 13 interviews completed and 37 survey respondents. But then one other piece I do just want to highlight here, this note on program confusion. We did try to confine the questions to ask specifically about the staff of C4SEND programs, but there is a potential likelihood that when folks answered, they may have been conflating other staff within the hospital system on labor and delivery, OB, wherever else, with the C4SEND staff. So we used two validated survey tools, one, the Client Satisfaction Questionnaire, or CSQ-8. You can see on the left the statements that were part of that people were asked to rate their level of satisfaction with. As you can see, we overall achieved very high levels of satisfaction, though there is, particularly with regard to the very satisfied category, a bit of a tailing off in those items at the bottom in terms of programs meeting needs, people receiving the services they wanted, and the amount of services they wanted. Again, combined with the satisfied category, we do still see very high overall levels of satisfaction versus dissatisfaction. But I do think this is an area that programs could potentially consider in terms of, talking to participants to ensure needs alignment and that the amount of services are adequate. We then also used a tool called the Discrimination in Medical Settings tool, and that contained a number of statements, again, that you can see on the left, and asked people how frequently those occurred. Do just want to highlight the navy blue here is the statement that these things never occurred, so that is actually the positive outcome that we would be looking for in these programs. And again, very high levels of folks endorsing that they did not experience these things as a result of the program, but again, a little bit of a tailing off in some of these items at the beginning about the kind of respect, basically, that people are treated with. And so even though these are small numbers, obviously always a concern if that's what people's experience has been. And so something to highlight, I think, for the programs. We then will move to the interview results. And so interview excerpts were sorted into 4 different theme groups: the perceived impacts that the participants had, the strengths and challenges of the program, and referrals. There were 16 themes sort of identified within these categories, and then they were categorized by how often they came up. So again, we had 13 interviewees, so a very strong theme is one that either everyone or almost everyone who participated in an interview mentioned. Strong would be more than half, and so on from there. This is an overview of all of the themes. As you can see, the most common or the highest number were in program strengths. We're going to talk a little bit about perceived impacts, strengths, and challenges now. Really encourage everybody to take a look at the quotes here. I know I'm going to be going quickly, but there's really wonderful stuff. So yeah, I want to highlight that improved well-being was a strong theme for folks in the program, and then retained or regained custody was a moderate theme. And in the case of improved well-being, as this quote illustrates, we're talking about things like, just folks feeling like they were taking better care of themselves and able to take better care of themselves because of the impact of the program, attending their appointments, paying attention to their health, and just having an overall healthier sort of pregnancy and postpartum. In terms of retained or gained custody, there were several people who did provide some level of credit or to their participation in the program for their ability to participate in and either retain or receive custody. And again, to DA Ryan's introduction, thinking about the ripple effects that can have for a family and a community. And then also just the opportunity for the state to really reduce that workload for DCF. In terms of program strengths, two things that came through as a very strong theme were non-judgmental staff and social support. So again, really highlighting the importance of any program like this in focusing on avoiding stigma, because there was a real contrast in what folks said in the interviews between the past experiences they had had with healthcare and social services that may have been stigmatizing and this program. And I think that led to increased trust, increased engagement in the program, which is really important. And then also a number of folks spoke to not having very significant or large social support networks, which are so critical in the pregnancy and postpartum period, and the program really being able to help support them through that. In terms, again, continuing with program strengths, connection to resources being a very strong theme, so almost everybody or everybody mentioned this, and then support related to DCF intervention. For connection to resources, just again, the importance of care coordination and that wraparound care, making sure that there's sort of a one-stop shop for the participants' needs to be met so that they can focus on their recovery and their parenting. And so, noting here again in the quote, connection to recovery programs, to doctors, to therapists, and then also those connections to community resources for the high level of health-related social needs that we did see in the data. And then programs spent a considerable amount of time supporting folks through the DCF and 51A reporting process, as the hospitals in our program had not made the types of policy changes that the DA alluded to in her introduction. And so a lot of time with plans of safe care, documentation to help folks and just helping folks navigate that process. And it was very appreciated by the participants. And then finally, sort of both a strength and a challenge, though moderate in both cases, is the presence of support groups in the program. So, folks spoke to how helpful having support groups in the program was, because they sort of felt that, other types of parenting groups would not necessarily be able to speak to the experience of being in recovery, and recovery groups were not always able to speak to the experience of parenting an infant. And so having that shared community space was really helpful to folks, but support groups were often not available on a schedule that worked for the participants, and a few did say that they wished they had been able to attend more. Yeah, so just to conclude, really just want to highlight and applaud the incredible work of the staff of our C4SEN programs, and the data that we have to suggest that there was a really high level of connection to critical evidence-based care, and then also that participants in the program felt that it was a non-judgmental and supportive place for them to get care and support to really improve their experience of pregnancy and parenting as someone with a substance use disorder. So if we have time, I can take a few questions, or if questions come up later, I can be reached at this email address. Thank you all very much.
questions, comments? Alice, can you see the chat? Do we have anything in the chat?
Hang on just 1 second. Let's see. We do have one. I've worked with clinicians who have independently filed 51As against mothers seeking detox.
Catherine, what have you seen as the impact of that, especially for somebody who is already moving forward, trying to get to a better place?
I know that's a concern that a number of the staff in our programs talked about is the challenge of those reporting requirements with respect to building trust with participants. I think that Lauren and Caitlin from our South Coast program may be able to speak to that as part of their presentation. But we did, another part of our evaluation that I wasn't able to discuss today was interviews with staff, and that was something that did come up about the challenges with, trying to build trust with participants, but then also eventually having to let them know that, yes, we will have to, this documentation will have to be filed, this report will have to be made, and challenges that came up around that. So that was something that staff spoke to. I don't have anything further besides what we heard from staff.
Okay. All right. Anybody else? Questions, comments? All right. Catherine, thank you. Thank you so much for that. Was useful information. Thank you. All right. Now, as Catherine mentioned, we're going to turn to Lauren Souza and Caitlin Catan, who are at the New Beginnings Moms Do Care program at the South Coast Hospital. Lauren is the nurse team leader of that program, and she comes to it with a lot of experience. After nursing school, Lauren began an 8-year career in early intervention. She joined the New Beginnings program in 2019 as a nurse postpartum care coordinator to provide ongoing services and supports to moms through birth and then 12 months postpartum. In November of 21, she began her oversight of the program, managing the hiring, the onboarding, the programming, the data collection, and serving as awards manager for the grants. In 2023, Lauren received the Eagle Leadership Award, and the New Beginnings Moms Do Care program is the recipient of the 2024 Penguin Hospital Team Award. Caitlin is also at that program as the program coordinator. She also has a long history of working in collaboration with the Department of Children and Families, having done that for 16 years. The last 7 have been as part of the New Beginnings program. She began there in January of 2017 as a family advocate, working directly with the patients, giving education, support, and advocating for them. In September of 21, she became the program coordinator and is the primary contact for program referrals, enrollments, provider outreaches, and completion of patient GPRA assessments for the grant. And they're both going to talk about the program as well as the grants they've received for that program. So thank you both for being here.
Thank you. I'm going to share my screen. So please let me know if you can see it and if it's in slideshow mode. I can't see anyone, so.
We cannot see the slideshow yet, Lauren.
Okay, 1 second. Now can you see it?
There we go.
There
okay.
we go.
Perfect. Okay, so thank you for that introduction, for inviting us to be here. Caitlin, do you want to start off the presentation?
Sure. So good morning, everyone. Thank you so much for having us here. This is a great opportunity. The Moms Do Care program, I'm not sure how much anyone is familiar with the program. So the Moms Do Care program is centered around an evidence-based peer-supported model, supporting pregnant and parenting people impacted by substances across the continuum of care. And as of 2023, the New Beginnings program with South Coast Hospitals became one of 11 Moms Do Care sites, bringing these services into the South Coast region in alignment with our efforts to improve access to care for our communities impacted by inequity. Next slide, Lauren.
Yeah, sorry, I'm trying to move.
That's okay. It's okay. So for this slide, as a multiple disciplinary team, we offer these services to address 3 priority goals, which are bridging the gaps in care to promote healthy pregnancies and healthy babies for optimal long-term outcomes, to support keeping birthing families together and offering the opportunities for them to reach their full potentials.
And I just also wanted to mention, feel free to stop us along the way. Caitlin and I
Yes.
spent a lot of time on this PowerPoint, but also we're kind of like, we don't really know what anyone wants to know. So definitely feel free to stop us.
Yes. So this is the program history. And just a little side note, I had actually, Lauren and I were talking this morning and kind of hoping to try and get like a where we started to where we are. You'll be able to see the progress we've made in a picture. But I had started as a family advocate working in a dictation room, which I'm pretty sure is like a 3 by 7 foot closet space. But the New Beginnings program launched in 2016 as an advocacy program that has continued to evolve into a now fully grant-funded care coordination program, serving pregnant and postpartum people impacted by all substances up until 36 months postpartum. So we have definitely come a long way. So with the early stages of the New Beginnings program, our phase 1 of New Beginnings included education on NAS, so neonatal abstinence syndrome, eat, sleep, console, and the DCF process provided to patients during their admission to the hospital. And what we learned during this phase of the program is that earlier identification was needed, which led to the next phase within the program. And we saw the addition of an RN to coordinate outreach to promote early referrals. And with that, we learned that the early engagement led to better outcomes, but there was still a need for more continued support after delivery, which led us to the next phase, including the expansion of services that offered postpartum care coordination through 12 months postpartum. And with that, we learned that the high utilization of services demonstrated success, but also a need for additional resources to continue. And I think that is really where the benefits of the HPC C4SEN grant really kind of took us to the next level. So I'll let Lauren take over from here.
Thanks, Caitlin. So it was in 2021, as Catherine so eloquently described and demonstrated, the HPC C4SEN grant. So we were able with that funding to really put into practice everything that we knew the program needed in order to succeed. So we restructured our staff, and these changes allowed for program oversight and workflow restructure to increase the focus on, for increased focus on promoting early intervention engagement. So patients would now work with their family advocate at the start of their enrollment in the program throughout their entire engagement in the program, with the additional support of an RN in comparison to the previous workflow, which included a family advocate from enrollment up until delivery, and then hand off to the RN, which was myself, for the postpartum piece. And that was kind of a disjointed care model. We also built a custom EHR platform to capture the quantitative data collection. And as Catherine outlined, we had the qualitative data opportunity working with JSI. We were able to gain a lot of great feedback. So here are some of our learnings. We learned that what was still missing on our amazing team was someone with lived experience to kind of inform our care delivery model. And the data offered great insight into the program's success, but there were opportunities for improvement there. So we could see the benefits of early engagement, the trends in the length of engagement and placement outcomes, but the opportunities for improvement were definitely modifying the metrics to optimize our output. So we noticed there were things that we were not measuring and tracking that were kind of missing to paint the full picture. And we needed to de-aggregate the reports to ensure that we were able to identify patient-specific trends. And that's where we kind of went back to the drawing board and restructured everything. And then we knew we needed to create a dashboard to allow us to see our data in real time so that we could closely monitor what we were seeing without waiting long periods of time. That brought us to our need for further funding, and along came Moms Do Care at the perfect time. So with that, we were able to add our perinatal recovery coach, a social worker for 10 hours, and a data intern for 10 hours. We optimized our data platform, and we work with our Moms Do Care TTA team to implement internal trainings for our family-centered unit. So what our takeaways have been so far in the last year are that our perinatal recovery coach has been informing policy and procedure changes, as well as cultural change among nurses and providers, and that has been really warmly received. Reflective supervision, reflective space have been extremely a necessary priority to support the staff as these changes have occurred. And with the growing team that brings such diverse perspectives, communication has been critical to kind of keep the homeostasis amongst the team and ensure that we are honoring everyone's diverse perspectives and integrating that into the work that we do. What we did not expect, Caitlin and I are very forward thinking, and we think we cover, we like to think we are very intuitive and cover it all and think steps ahead. What we did not expect was the increase in mental health needs that we are seeing as we expanded our eligibility criteria. And then also the increase in out-of-home placement, which we are continuing to monitor really closely. And what we are correlating are some racial disparities in those out-of-home placements, as well as a trend in mental health diagnoses for those families that are seeing out-of-home placements. So here is a quick little snapshot of what our new dashboard shows us. So, it doesn't look like the numbers transferred over, but I want to say the number of patients enrolled. Caitlin, I don't know if you have the screenshot still. I might be able to pull it up on my other tab, or I can put it into the chat after I get out of this screen, but I want to say it's 113 patients that did not enroll and 238 that did, something along those lines. And this is the number of patients that were referred. So these numbers here are much more significant because it would reflect, the total patients here. So we are continuing to get a high percentage of patients that are referred prenatally, which is our goal, because if we can get in contact with them prenatally, we have better outcomes. We have more time to engage. So this is this is the most basic data that we collect. Other things we collect are if the patient is engaged in pharmacotherapy at the time of enrollment, if they are being discharged home with the baby, what are their feeding plans for baby? Did that end up happening? What we're trying to look at is breastfeeding being supported if that was their plan? If not, why? trying to monitor that. We're doing a lot more mental health screens. So for the PMADs, monitoring those results to see if there are any trends prenatally, at delivery, and postpartum, if there are referrals needed for that, service utilization, all of those things. So as you can tell, this is the most basic. And then for our next steps, we are continuing to identify resources to meet the current and growing patient needs, as well as identifying billing opportunities for braided funding to support sustainability. As Catherine demonstrated, our program size is really large, and I didn't include the screenshot from the NIS dashboard, but the South Coast region continues to experience the highest rates in babies born with exposures, and that is just for opioids, and now serving patients that experience impacts from all substances. Our program is growing really quickly. So yeah, we need more resources, and we're continuing to work on breaking down the internal and external silos to improve the collaboration and coordination of services so that our families are receiving quality, trauma-informed, and culturally competent care. And the most exciting is we're opening a space in the community for pregnant and parenting people impacted by substances to promote connection and relationship building in populations that have experienced isolation and stigmatization. And we are going to be connecting with Project Promise before this very soon opening, as they're doing similar work. And although we think we've thought of every detail, there's probably more to learn. So this is just a snapshot of what our space will look like. 3,600 square feet of space to welcome our families and facilitate groups and meet one-on-one. We have a large space for lactation and a little nursery area for moms that need to put babies down for a nap. We have a large play space here, conference room to facilitate providers to come meet. And we've never had a home base, so we're really, really excited for this. And I did forget to put our contact info, so we can put that in the chat. But we are open to questions.
I actually have a couple questions.
Yeah.
So this team that gets assigned, the recovery coach, the social worker, can you just clarify at what point that happens?
Sure. So the whole process is patient gets referred, Caitlin receives the referral. I like to call her the face of our program. So she's, the warm welcome. She will do the enrollment, and then she will assign a family advocate. At that point, if there is a need for a recovery coach, then a recovery coach will get assigned. If there's no need for a recovery coach, for example, if a person is assigned based on marijuana exposure, probably no need for a recovery coach, but who knows? So that determination is made. But then that person, the patient who's referred, would work with that family advocate throughout. When the initial meeting happens with that family advocate, the nurse also joins that initial meeting. Our social worker is only 10 hours right now, so it's more of a consult as needed for high risk situations, and we're really prioritizing additional resources to increase her hours because that's our biggest need right now.
And what triggers the referral?
A referral can come from any provider, or the patient can self-refer. Where we typically get most of our referrals from are from OBs upon identification of eligibility, so identification of exposures. So it could be from a positive expert screening. So a lot of providers, I shouldn't say a lot, some OB providers are doing screenings during the prenatal visits, like the 5P screening. So they might identify the person's at risk for substance use and might refer. Could be a positive tox screen. We developed a identifier report so that if a person has, there's a whole list of like different areas that we pull data from. But if a person presents at any South Coast touch point and has the presence of an eligibility factor, then they pull to our identifier report and Caitlin will outreach to that person. So these things, the sources are toxicology reports, diagnoses list, medication list. What am I forgetting, Caitlin? There's like quite a few. The report was not fun to build because unfortunately, a diagnosis of the SUD or OUD is not like necessary criteria because we don't go through insurance. So we couldn't just defer to a diagnosis list. It could be just a positive tox screen. Services are also voluntary. So we're just trying to reach out and offer and say, like, you know, you're eligible, you could benefit. Services are also tailored to what the family wants. So like, hey, we're here if you want us. You meet the eligibility criteria, and here's how we could help. So we're trying to identify anyone that could be eligible. That's kind of that. Yeah. Any other questions?
Marion, you're muted.
Sorry, any other questions, comments?
I just have a question. Great presentation, Lauren and Caitlin. You mentioned needing more resources. What kinds of resources do you need?
Yeah, so definitely funding to increase our social workers' hours, and we need another peer recovery coach. We're also looking for funding to support transportation. We want to be able to get our moms to treatment. Often when we identify like a detox or a residential place, like a bed, it's like, you got to go now. And so PT1s are not an option. There's no time to set that up. We also want to get our moms to us now that we have this space opening. And the space is in New Bedford, but we have 2 hospitals, Fall River and New Bedford. So not everyone, you know, is local. And it's difficult to travel with like a newborn and maybe they have other children. So, you know, we have vouchers, but we have limited funds for additional transportation. So I would say those are our top priorities, with staffing and transportation funds.
And as we've said, and you just heard, you know, especially in this county, we are so large. We are 877 square miles. Transportation is a continuing challenge because in the places where we do have public transportation is expensive, especially if you're coming or going, you're going often, you're bringing other kids with you, that sort of thing. And we have parts of this county where transportation is just really, really difficult, very rural parts of the county. Yeah. Well, thank you both. That was great. That was a great presentation. I'm excited about this. Maybe we'll come on a little tour.
That's what I was just going to add, that you are all welcome to come and visit us. If you're interested in coming to the ribbon cutting event, which we don't have a date yet, definitely
we expect that soon.
Yes, don't hesitate to reach out. Come visit.
Send that to us and we'll publish that to this group. That would be great. Thank you both.
Thank you.
Thank you.
Now, our next presenter is Dr. Elizabeth Yen. And Dr. Yen is a physician scientist whose research is really focused on the impact of maternal opioid use, both long and short term, on babies. And as a neonatologist, she obviously sees firsthand the immediate withdrawal signs in babies who've been born with opioid exposure. And one of which is, and you've heard a little bit about this, the feeding deregulation. And that often leads to growth challenges and prolonged hospital stays. And by using non-invasive methods, such as the baby's saliva, brain MRIs, and body competition studies, they're able to really, she and her team have really been able to develop some innovative work and conclusions about things that are happening. And, Dr. Yen has really talked to us about how much inspiration she has drawn from the families that she serves and her real commitment to advocating, to doing research, and then being advocates for families in need of this help. So, Doctor, I'm happy to welcome you here this morning.
Can you all hear me?
There we are. Yes,
okay,
we can
perfect.
hear you.
Perfect, yep. Thank you. I'm gonna just reshare. So thank you, dear Ryan, and all the team for the kind invitation. I'm really honored to be part of this meeting today. So I'm going to be talking about the impact of the opioid epidemic in newborns, and the title is Beyond Hospital Length of Stay. I have nothing to disclose. And the objectives of my talk today is actually twofold. The first one is to provide the molecular and neuroimaging biomarkers of the effects of maternal opioid use. And the second one is to highlight early evidence of this adverse metabolic and developmental outcomes in this high-risk infant population. As we all know, in the last 10, maybe 20 years, there has been more than 5-fold increase in the incidence of neonatal abstinence syndrome, or NAS. And the cost is now being more than $2.5 billion annually. And every 15 minutes, one baby would be born suffering from this withdrawal. So at the end of my talk, another baby would be born from this really horrible condition. And as we talk, I'm going to start using acronyms of NAS or NOWS. NAS is neonatal abstinence syndrome, and NOWS, some people use the term which stands for neonatal opioid withdrawal syndrome. It is truly a multi-organ effect, as we all know. And it is really hard to manage this condition only because of the multifactorial factors that affect this condition: maternal characteristics, drug characteristic, what mom's is using during her pregnancy, the genetics and epigenetics of the condition, as well as the neonatal characteristics, whereby, for instance, sex of the baby affects the severity of the withdrawal. And on top of this, we are in the midst of the subjective scoring systems, either the modified Finnegan scoring system or the Eat Sleep Console that a lot of people now adapt. It is really hard for us to know is, certain scores really represent the severity of withdrawal, or is it more from the perspective of the subjects who score them? So there is an urgent need to understand the molecular mechanisms underlying NAS. What is the objective evidence of the impact of maternal opioid use? And a few years ago, I was invited to be part of this convening of NAS, where we actually try to even go to the bottom of what is the definition of NAS. And I like to use this term because it really captures the common pattern whereby women do use opioids as the primary medication, but there are also other substances, as we all know, psychotropic medications such as benzos, SSRIs, or tobacco that can present in a similar withdrawal signs. And the clinical signs that are characteristics of withdrawal is, excessive cries, fragmented sleep, tremors, the muscle tone, but very interestingly also this GI dysfunction, such as hyperphagia or feeding issues. And I'm going to really focus my talk today on this GI or feeding issues because it really affects their nutrition and growth. So as a neonatologist, as dear Ryan has mentioned, one of the first things we notice early on is that these babies have a very unique feeding phenotype. They want to eat a lot, they are hyperphagic, but at the same time, they have feeding difficulty. They are blabbering all over, they cannot coordinate. So what is the connection between maternal opioid use and this very unique feeding phenotype? And as we know, the modified Finnegan scoring system have this scores for babies who have excessive sucking, they give a score of 1. And those who have a poor feeding, infrequent, uncoordinated suck, they give a score of 2. So it is one of the things that are actually being evaluated. animal studies showed that opioids affect the hypothalamus, and the hypothalamus is a very central, crucial brain areas that control feeding behavior. There's this area that is responding to energy or homeostatic signaling. I'm hungry, I'm gonna eat, I'm full, I stop eating. But there's also another area that responds to this reward or dopamine hedonic signaling. In other words, I'm full, but I keep eating. So there is this dysregulation by which opioids create the imbalance in these two signalings. And mice who are exposed to opioids, they have this predominance of this reward signaling. So even though they are given, normal chow, they are full, they still wanted to keep eating, and particularly high fat, high sugar food. So then using baby saliva, I picked 4 genes to understand this hypothalamic and reward dysregulation, in particular, the neuropeptide Y2 receptor gene, or NPY2R, POMC, or propionmelanocortin, leptin receptor, or LEPR, and dopamine D2 receptor, or DRG2, which is the reward. And the idea is that in babies who are exposed and hyperphagic, there would be a decrease in the NPY2R, LEPR, and POMC, which is the anorexigenic signaling, and an increase in that reward or hedonic signaling. And what I found is very interesting. I'm going to orient everybody. I don't know if you can see my cursor, but on the x-axis is the group, control versus babies who have NAS or exposed to opioids. On the y-axis is this dopamine receptor type 2, or DRG2, this key reward gene. The blue is for boys and the red is for girls. And this delta CT values from 0 to 25, it is actually inversely proportional to the gene expression level, okay? So the higher the delta CT, that means the lower that gene signaling. So as you can see, in babies who are exposed, males have a greater of that reward signaling, and female has lower, right? Because this delta CT is higher, so they have lower DRD2. And when I break it down by severity of their NAS, the boys who get treatment remain to have a greater reward signaling compared to the females. And interestingly, within my cohort, it is boys who require more treatment or more severe. Correlating this with their feeding behavior. Look at the blue lines here. And it can be confusing because of the opposite direction. But what these graphs are telling us is that the greater their reward or DRG2 gene, the more they take, all right? Greater reward signaling, more food or more milk that they take. So what I gather from this pilot data is that this is the first time we actually show with the molecular evidence that aberrant reward signaling may predispose this baby to this hyperphagic or severe NAS. So as they are in utero, they have all this dopamine from the maternal opioid. When they are born, they need to replace it with something because maternal medication do not continue through that placenta. The cord is severed. Now they are getting this from this feeding or this food, okay? And that begs the questions, what are the implications of this high reward gene signaling for future reward-seeking behavior, either through food or drugs, which can be perpetuated in later on? Then based on this information, I start wondering about what happened to their growth, right? As these babies have this very aberrant feeding behavior, I'm really interested to see this growth pattern. And again, drawing back to the drawing board, I'm looking at 2 of the markers that really represent this growth, particularly on their insulin sensitivity, because insulin is very important for the growth of these babies. So I look at adiponectin, or AdipoQ, and adiponectin receptor type 1, or AdipoR1. And again, these are 2 markers that present insulin sensitivity. And in adult literature, we know that low adiponectin and low adiponectin receptor type 1, these are implicated in obesity, in future adverse health outcomes, such as type 2 diabetes, fatty liver, and so on and so on. So low adiponectin and low adiponectin receptor 1 and 2 These are signals for poor insulin sensitivity. So to, again, study the babies, again, there's not much known about what happens to this baby. I look at their saliva. I also combine it with this body composition machine. It is called PPOT. The brand is here. But all this machine does is actually using air displacement plethysmography method. In other words, instead of telling me how much a baby weighs, 3 kilograms, it actually can calculate the percent fat in this baby. Right? So the baby will enter this warm chamber, very quiet, they're cozy. They enter that, and then the machine will tell me, oh, this is 10% fat mass. In addition, I also use this caliper to look at the flank thickness. And this is also another method to look into the percent truncal fat mass. And what I found is that this is the demographic data, just the chart review. And this has been shown consistently whereby babies who are exposed to opioid, they are smaller, right, by the birth weight, length, and head circumference, significantly more of the small for gestational age. And then also they have a greater incidence of exposure to maternal smoking and maternal hepatitis C. So this is what we saw on the paper. What happens to their saliva? So looking at these two biomarkers, the adiponectin and adiponectin receptor 1, again, high number means low expression. What we saw is that in exposed infants, their adiponectin and adiponectin receptor 1 actually are reduced. So again, remember these low values are associated with like a poor health outcomes, in particular metabolic syndrome, diabetes, and obesity. And when I broke it down by sex, females versus males, similar pattern, significantly lower adiponectin and also adiponectin receptor 1 in both males and females. And looking at their growth, if you look at the left panel, their body mass, the opioid exposed is in red, they are significantly smaller, which has been shown again. They have lower percent fat mass. They also have a thinner skin fold. If I follow them at 4 months, this significant disappear. And you can even probably see how the red bar is actually a little bit higher. It is not significant, but this shows that there is a reversal of this, from being skinny at birth to getting a little bit more and catching up compared to the not exposed. And even though their percent fat mass total is still lower than the non-exposed, their skin fold is actually greater. Again, the truncal fat mass. Then I followed these babies and looking at their serum lipid panel. Because again, no one has looked into what happens to this baby when they have a aberrant feeding and aberrant growth. And interestingly, if you can see, the numbers are small, 12 exposed and 5 non-exposed, but the total cholesterol, the low density lipid or LDL, which is the bad cholesterol, and this total to HDL or good cholesterol ratio, they're all elevated in the exposed group. And this total to HDL ratio is a marker or can be associated with future cardiovascular, a poor cardiovascular outcome. So again, very interesting data that came from just looking into their serum lipid panel. How about the brain? We talk about hypothalamic regulation, the feeding, the growth. How about the brain? My colleagues at Johns Hopkins University actually did an animal study, and pups who are exposed to methadone have this evidence of heightened peripheral and central, so throughout their serum and in the brain. And if you can see, all these purple bars are somewhat higher in the pups who are exposed to methadone. And looking at the biopsy, if you just see, it's really not important to know exactly what it is, but if you look at the red color, those are the microglia, the scaffolding for the brain growth. The left column is for the non-exposed pups. The right one is for the exposed. As you can see, there are definitely less of these reds, right? Much less. And if you can, even these white dots, those are the markers for brain growth, not much. And this microglia is very interesting. When they're happy, they have this finger-like projection, very colorful, a lot of these projections. But in the pups who are exposed to methadones, look at how few there are. They're almost like not reactive and not growing. And does that translate to their behavior? And this is a busy slide. My colleague did a lot of like this battery of tests to look at how much failure they can perform, or like cognitive ability to learn new things. But bottom line, methadone significantly impairs cognitive function in adult rats. And she did not study buprenorphine, but the idea is that opioid exposure during pregnancy affects not only on the serum, the brain, but also behavioral performance and cognitive performance. So based on this data, I look into the babies because, again, there are a lot of animal data, but what happens to the baby? So I'm looking at the MRI of these infants. And when I first did it, the radiologist called me and said, hey, Liz, do you know this baby has this white matter hyperintensity? I'm like, what? What does that mean? I don't know, but I just found out that there's this, punctate dots, very subtle. And when I'm he is actually blinded to the status of the baby, so he doesn't know which one is exposed or not. But I look at the data, I'm like, oh, interesting, this baby does have a prenatal opioid exposure. And then he called me with the second, third babies. I start making this connection. I'm like, wait, is this like increasing the risk of this white matter hyperintensity? And as I'm doing this, a group in Cincinnati reported similar finding. 8 of their 20 infants, and again, at this time, no one had done any of this neuroimaging, and we don't usually do any MRI. This is purely because of research. She also found 8 of their 20 babies have this white matter injury, and these are the similar pictures that she reported in her publication. This very like subtle, white dots. You almost can probably like miss it, right, if you're not a radiologist. So based on this finding, what I added to the literature is this salivary gene expression. And I'm really interested in the inflammation because no one has looked into the inflammation, but based on the animal data, I got really curious about the inflammation markers. And lo and behold, babies who have white matter hyperintensity represented by red, they have significantly greater inflammation markers, IL-1 beta, IL-6, TNF alpha, compared to those who do not have white matter hyperintensity. And this is an interesting finding where the anti-inflammation, or IL-10, is also significantly greater. In other words, it looks like these infants are very inflammatory, but there are also some defense mechanisms to counteract this inflammation. And we don't know what the outcome of this white matter hyperintensity. So that's one of the research that I'm doing right now to follow them. My students did another mode of analysis on this brain MRI. The white matter is a macrostructural on the macro level. What she did is something called fractional anisotropy, and this is to look into the microstructural, particularly the myelination of this white matter and what happens. So busy slide again, very colorful. These are all the tracks that cross over the fibers that cross across the brain. But what is interesting is this bottom figure. All this blue colors just show the decrease in the opioid exposed infants. So babies who are exposed to prenatal opioids, they have a lower fractional anisotropy or lower myelination. So very similar to the rat data where the finger light projection is very dampened in the exposed rats. We cannot do a brain biopsy in these babies, but this is one of the evidence that it does affect their developing brain. My team then conducted this a very simple questionnaire called Ages and Stages questionnaire. It looks at 5 different parameters in the developmental milestones, and we look at 2 months, 6 months, 12 months, and 24 months. We call them, we email the moms who originally participate in my initial salivary study, and then we now look into what happens to this growth. So what we say, these are the 5 categories: communication, fine motor, gross motor, problem solving, and personal social skills. As you can see, the red is for the opioid exposed. The black is for the non-exposed. And it is hard to tell any difference, right? You even probably can tell like, oh, interesting that the opioid exposed actually report that their babies are doing good. They're doing well and actually maybe better. But if I draw the line at 12 markers, what you see is that beyond this 12, you start seeing this widening disparity in the outcomes. So just to point out, if we only follow this baby up to 1 year, we may miss what happens to the following. If I extrapolate this data, look at what happens. This disparity is going to get wider and wider, right? So by 4 years, if I plug in and use this calculation, there will be about 30, 40 points difference in their scores in the 5 categories. So again, emphasizing how important it is to follow these infants. At Tufts, we do have a referral for EI, and I'm glad that I did hear that from Catherine's talk as well. So from 2016 to 2018, we have a very poor EI, really babies who are eventually enrolled in EI. Even though, in the hospital, they are all eligible because of the diagnosis. When we work with the Department of Public Health and look at the linkage of the data of what happens to these babies after they're referred, a lot of bars, but what is important is this 3, and maybe the last bar. This is babies who are actually enrolled. From eligibility, which is 100%, to when they are finally enrolled, only 8%. And then as we saw this data, we tried to tell people, oh yeah, please refer, please refer. It went up to 12%, maybe 24% in this span of 3 years. So then what we realized is that it's probably because there are different providers who refer these babies to EI. Can be doctors, social worker, nurses, or whoever they have encounter with this family. So at 2019, Cecilia Sibis, our physical therapist leader, and she's very involved and she's very passionate about EI. So we then have this idea of what happens if we just streamline our referral and use the consultation of a physical and occupational therapy as a place to refer EI at the same time. So all this baby got PT and OT referral or consultation. And what happens if they're the ones who talk to mom at the same time about EI? And what we have seen is that our enrollment eventually getting better. It is still far from perfect, but it is actually working better than before. And what we see is that this is an average of it. Again, these numbers are what is very interesting for us to see, just looking at the streamlining the process. And my student actually created this brochure. And again, with the collaboration with DPH, we have a video that we put in the QR code, and we provide this to all the parents. We talk to them when they are in the hospital, and we give this pamphlet to them, and they can review and remember and contact the EI referral. So to conclude, hopefully with this quick overview, we know that maternal opioid use affects offspring feeding behavior, growth, and brain development, and there is clear objective molecular and neuroimaging biomarkers. It is unclear what happened to their metabolic and developmental outcomes, as this research is only very limited, and we're just seeing this early evidence. But it points to the importance of robust anticipatory guidance before these families are discharged from the hospital. And more importantly is that the follow-up after they're being discharged from the hospital. And this research started very small with saliva during their hospital course, but now it has gone beyond this. And we're actually following these babies after they go home, looking at their saliva, bringing them back for this brain MRI and the P-POD measurement, and filling out nutrition questionnaires, lipid panel, and the ages and stages questionnaire that I mentioned earlier. So I cannot thank enough my mentors, my colleagues in Mary and Tufts, at Mass General Brigham, and all the generous funders who have provided funding to this important research. And I take any questions from the audience.
We do have, it looks like Dan has made a couple comments in the chat. Dan, do you want to just share those, both of them, and ask the questions directly? Is that okay?
Yeah, absolutely. So my first comment was actually just, kind of, I have a cousin who used heroin from 14 years old until his late 20s. He got into recovery. He's been, clean for 15, 16 years now. But I was talking to him about how he had started going on testosterone. And one of the things that he said he was, he had been tested, he had low testosterone. And one of the things I know about opioids is they actually suppress testosterone. And I'm wondering if, like, when you have, young adult males using opioids, if that like constant testosterone suppression, can have this sort of long-term lifelong effect. So that was like one tendril of a thought. But the second question that I had was kind of based on what you were talking about around how, there's, exposure to methadone or other opioids, causes inflammation, this cognitive suppression. And it makes me wonder, does that mean we have sort of like this large scale population of people who are experiencing cognitive suppression because of either illicit opioid use or medication assisted treatment, and then that's passing down generation to generation?
Those are such important questions, and I cannot emphasize enough. Through this research, sex differences is crucial, and we see this at the adult level with males who are using opioid. There are greater risky behavior. They have a higher incidence, but females actually have very interesting a comorbid condition, psychiatric condition. Once they use, they are the one who much harder to stop, or once they stop, they have a greater incidence of relapse. So very different phenotype. And this probably stems from early on. But to comment on your question about testosterone. So I was at a talk recently about animal data where, not related to opioids, but they were talking about how dysregulation in the brain, and specifically this HPA, hypothalamus, pituitary, and adrenal axis, can present to a multi-organ system or functions disturbances. And because of the hypothalamic dysregulation, again, that is along the line of the HPA axis. And these hormones, the FSH, LH, that affects the gonadal development later on. So I think there is something to that. I have not done the testosterone level, but it is very interesting that you commented on that, only because this sexual dimorphism in the brain can affect a lot of organ system that we see. In my for my field, it's just a baby's presentation, but looking at this development, puberty, and how does the sex chromosome interacts with this sex hormones, that is a different, really interesting field that I know with more finding, hopefully we can entertain and see what does that mean for their predisposition and their risk for their using behavior, right? So I think that is one question. This transgenerational effects, I really believe there's something to that, because you can raise very important question. Just because a mom uses it, it does not stop in her baby only. It actually stays, and it can affect this generation after generation. So this connotation of intergenerational compared to the transgenerational, it is so important. That's why I really believe that we talk about stigma, about making sure that we don't stigmatize parents. And this is so true. And we don't take away those resources. We don't take away those referrals to reduce stigma. I think we need to empower these moms and tell them, give them the idea that, it doesn't stop in this pregnancy only. It can affect your babies and her babies and on and on. So I think that is a very important advocacy that I always tell the families, empower them. You're doing the right thing, but you need to continue to get resources, stay with the programs that you are in order to better not only serve you, but also your babies and the future generations. I hope that answered your question. But
yeah, no, absolutely. And if I may, it makes me think that, this evidence, this should be discussed with clinicians. I worked in buprenorphine treatment programs for a long time as a social worker. And I worked with a lot of physicians. We gave out a lot of buprenorphine, right? And, there were people that I worked with whose treatment with buprenorphine was 4 to 6 times longer than the time that they were using illicit opioids. They had been on Suboxone for 10 years, but they had only used opioids for 2 years, right?
Mm-hmm.
And so, you know, we as a society, we think of this as harm reduction, right? We're preventing the relapse, preventing overdose, and that's good. And what are the other effects? And this is what you're actually showing right now, that there are these other effects that happen when you consistently expose someone to opioids over a long period of time. And I think that this is the kind of thing that we should be bringing to, you know, clinicians, so that we can update our protocols in prescribing and saying, no, like, we shouldn't be doing these long maintenance things, if it, you know, these long maintenance protocols, unless absolutely necessary. We really should move to more like a tapering schedule to prevent, you know, long-term exposure, because it is having these kinds of effects, and that can cause a lot of unwanted consequences. You know, if you're having cognitive suppression that is passing on to children of these parents, you know, like, no one wants that, right? Like, that's not good.
Yeah, no, absolutely. That's very good comment.
Yeah.
Thank
So
you.
thank you so much for presenting this.
No, thank you.
Catherine, do you want to jump in with your question?
Yeah, I think very related to what you and Dan were just discussing. I think thinking about how we just are, you know, balancing risks really, and curious whether there has been research that looks at the degree of these impacts versus in a case where the only exposure was to MOUD versus to other forms of opioids. And is there any distinction, or does, you know, it all, has that research been done? And then is there any distinction in the impacts?
No, absolutely. I think this is really relevant question, Catherine. The data that I just presented, majority, 90%, they are on the MOUD program. So only
exclusively, or in potentially in combination with some illicit use also.
They do have a polysubstance, so they are in the treatment program, but they do have polysubstance. So that polysubstance is really hard to eliminate. But they are not, you know, they're not using any illicit opioids. They actually come to the program and maintain and adhere to the program. So those are the data based on the MOUD, not pure methadone or buprenorphine or a Suboxone maintenance program, but MOUD plus minus other substance. So that is the data that I'm presenting for today. But that really begs the question, like, you know, again, to what Dan was mentioning, it is important to balance that risk versus benefits. Like, how long do you can we start tapering after pregnancy?
Right. And then similarly, also knowing that there can be significant developmental and cognitive impacts from the trauma of either having a parent in active addiction or the kind of removal and you know, the child welfare system. So a complicated series of risks to balance. And so I do wonder about what is the way to present this data to people. So obviously they're informed about, you know, what the situation, the risks, the follow-up care that infants might need, but not in a way that might lead people to sort of like forego a treatment that could be very helpful in presenting even worse and preventing even worse outcomes.
Absolutely. I think a lot to be done for sure. Not only just that, like, you know, you got to stop consuming, but again, what else can mitigate these effects? For instance, what Lauren or Caitlin was mentioning about the use of breast milk, which we know is very, very low in this population. That actually has a lot of like this counteracting effects on the development, right? So how do we, maybe while we're telling parents, oh, you know, you have to start thinking about these effects, you know, do the counseling about breast milk feeding. It can be as simple as that. And people often forget about other things. People think about the medication, but this social effects really impacted.
And then also certainly like longer term research about what's the effect of EI, what kind of educational interventions, just because this is such a new sort of generation that's had specifically this MOUD exposure.
Yeah, exactly. Yeah.
Thank you, Dr. Yen. That was so incredibly informative. And thank you to all of our speakers.
Thank you.
If you don't mind, if you're willing to share your presentations, if you could email them to Emily Rogers in the event that you don't mind, and then we can share them with the group. Okay. Thank you so much. We'll see you all next month, and hopefully our speakers will join us next month too if they can as attendees. Thank you. Have a great month, everyone.
Thank you. Take care, everyone.
Bye.